talk about CAR T-cell therapy a little bit. And if you can share what your strategy looks like when you think about CAR T. Do you see it replacing transplant? Do you want to use it earlier in lines of therapy?
Okay.
How will you approach CAR T-cell therapy for your patients?
Great. So I'll take a stab and I'll let the others chime in as well. So CAR-T has been shown to be beneficial in the late relapse setting based on the CARTITUDE-1 trial and the KarMMa-1 trial to begin with. So the responses that we were seeing were so deep and so good, and you saw that 30% of the patients did not need any treatment 5 years after, and most of the patients have prolonged responses. That same benefit was seen in the early relapse setting from the KarMMa-3 trial and the CARTITUDE-4 trial. Both these trials showed that if somebody has received a transplant and was on maintenance and they're progressing, they're eligible to receive these new CAR-Ts. So what we had seen was a shift in where the benefit was initially seen, and now we're seeing it in early relapse setting. So Dr. Joseph led another trial at our institution where the benefit is being evaluated in the frontline setting. So current standard of care is anybody that gets diagnosed, they get a 4-drug treatment, get a transplant, and go on to maintenance. So this trial has evaluated half the patients would receive the transplant, half the patients would receive a CAR-T. So the results would be available probably in 2029. So we would not have any changes in the standard of care probably in the frontline setting until the time we do have clear evidence that one of these options is beneficial compared to the others. So that's where I would stop.
Yeah, I think I was going to mention that's the CARTITUDE-6 trial, so we're currently waiting results of that. I think the question of will CAR-T replace transplant, we don't know yet. I will tell you when we look at data internally or in clinical trials of remission times with transplant, they have not yet been beat in any CAR-T trial. So when we look at the Perseus trial, which looked at quadruplet induction with transplant and then maintenance, the projected remission time is north of 14 years. We'll see if that's how the trial reads out, but that is very impressive length of remission. And so we really need clinical trial data to show us if CAR T-cell therapy is just as effective, if not more so. I think in terms of how we currently use CAR T-cell therapy now, I think the main kind of take home of KarMMa-3 and CARTITUDE-4, which Dr. Nuka just described, is that we should be using CAR T-cell therapy earlier. I think it's a discussion between the patient and your provider about where. I don't think in general, at least I don't, I know the group doesn't take everybody at first relapse, but I think the general take home is that these drugs work better earlier and they're tolerated better earlier. So if you're able to use them earlier, that's when you should do that. In general, I'm thinking about it early, meaning first relapse, for high-risk patients. So that means either you have high-risk genetic features, the myeloma has high-risk cytogenetics, so those are things like deletion 17p or 414 or something like that, or you don't have those features, but your myeloma is behaving sneakily. So we're not getting those remission times we expected, the myeloma is relapsing earlier. Right? That is a myeloma that's not behaving the way I expect it to behave, and that might be a good situation to switch targets on them to confuse the myeloma and use CAR T-cell therapy. And that in general is how at Emory we approach CAR T-cell therapy. If someone is already many lines in, that's different, and we might think about CAR T-cell therapy at late relapse. If someone is early in the pike and they're relapsing early or have high-risk disease, we think about CAR T early.
Okay, great. We have a question on this side.
Hi. First, just thank you so much for all the work you do. I'm really glad to come today. It's inspired a lot of hope, and just really grateful for this day. So listening to kind of the state of the current science is both inspiring and also overwhelming. And so sitting here, I'm like, okay, he's got quadruple trial, post-transplant maintenance, normal risk, MRD negative. and it looks like there's cell mods, super mods, bispecific options, maybe CAR T is the way to go. How does someone make a decision about, I know it's in conjunction with your treatment team and recommendations, but given kind of the state of the science and how we don't know so much about kind of longitudinal implications or safety profiles, like what would you recommend for families who are trying to consider all these factors in terms of thinking through, if we had options for trials, like which risks or benefits to kind of consider in making these decisions?
I think it's a really good question. So I think the first thing I'll say is, because you heard a lot of data, not all of these drugs are available in each setting. So I think that's important, because sometimes it feels overwhelming. Everything I spoke about is not available till late relapse. The bispecifics are late relapse, so the choices are different, right, depending on where you are. Particularly if you're newly diagnosed or earlier in the course, it's much more prescribed. There's not as much choice. Having said that, we have clinical trials in all of these settings. So I think my advice would be, anytime I see a patient where we always, if we have a clinical trial available at Emory and most academic settings you're gonna go to, we think it is part of the Emory experience to talk to you about what clinical trial options we have. So that should be part of your visit, particularly when you first see us. This is standard of care, and these are things that you're eligible for. The way I approach it when I talk to a patient about standard of care versus eligible is we talk through the risks and benefits. This is standard of care. This is what we know about standard of care. These are the benefits of standard of care. These are the side effects we know about. This clinical trial has the potential to do X. It could potentially have an improved side effect profile. It could potentially have a better remission. The downside is it's a clinical trial. So you might have more visits. There might be, logistical things, there might be cost things, et cetera. So I think it's just a discussion and making sure, if the question is about clinical trials, there's a consent form that goes through kind of these nuts and bolts, and I think it's discussion, and it's what are you willing to give on, and what kind of things are you open and comfortable doing, and what are you not? And I always say, and I'm sure we all say, this is your option. If you want to do it, great. If you don't want to do it, no problem. This is the backup standard of care.
So I'm a caregiver. My wife just got diagnosed with MM in July of this year. Totally unfair question to this panelist, but I want to ask it anyway, which is, as we head towards the consideration of doing a transplant in December or January, how would you compare, it's tough to ask this question, but how would you compare the care from Emory versus Northside, and how much does the Emory staff, he's smiling now, how much of the Emory staff feeds data to the Northside and other local hospitals, so that we would, as a couple, my wife and I, know that we're getting the best care? Yeah, I know that's
Well,
tough.
I just told him he needs to get a second opinion from a specialist.
I think that's probably, I'm going to stop talking after this. That's probably the best thing. I would get a second opinion, look at your choices. If you're asking us how we partner with the Northside BMT group, we don't funnel, we are separate entities. So that is, we're not funneling data to them. So if you go to them, you're going to get their opinion, their experience, their approach, and then we do things a little differently. And so I think that's probably the best, to kind of look for yourself and see. Yeah.
Yeah, I think I would like to add, I think it's always beneficial as a patient, or if I were a patient, or if my family member was a patient, to always have a specialist or an expert in that particular cancer on your case. Many times, our community oncologists, we share a great relationship with them, and we need them, and they need us, and we have a really good rapport. But community oncologists, they're excellent at treating all different cancers, and we are specialists in one particular type of cancer, so we know that cancer a lot more in detail. we would probably not be able to do the 100 different types of cancers that they treat. So kudos to them for doing that, and I really respect them. But if you wanted like more nuanced discussions about a particular type of cancer, it's always better to have a specialist on your case. And so, and I think your doctor should be totally supportive of that. If you want to have like a myeloma specialist on your case, I think you should ask for that and advocate for yourself. And I don't think your primary doctor should have a problem with that.
I'm sorry. So quick follow-up. Are you saying Emory is more of a myeloma specialist than the, let's say, North Side?
So in Emory Winship, we do, all of us actually have disease focuses, and we practice only that. So all of us that are here on the stage, we only see myeloma patients. So although we are trained to treat all of the cancers, of course, but we've specialized in this particular type of cancer, and this is how our practice is.
I'll make a comment on the question. So if you look at all the large myeloma programs in the country, we probably fall into the one of the largest programs in the country. So I can't differentiate whether it's North Side, who's better and who's not better, but you probably can see we have 9 myeloma physicians in one group under one umbrella, and we offer uniform care, and we're regarded through the country, not in the state.
And one way you can ask that question too is how many cases of myeloma is this physician treating? Because that will give you an idea. When I did this with my local oncologist, I got diagnosed through a local oncologist, and I said, how many myeloma cases are you treating? It was 5. And then I asked how many myeloma cases, because of my brother-in-law's experience, I knew I should get a specialist on my team. And I asked them how many cases they were treating. At the time, it was 600. So you see the pattern recognition difference between probably thousands at Emory versus a handful by a clinician. So that's the difference. When you're making treatment decisions, I suggest that because you may have access to a clinical trial that you could join, or that's early access to a program or something like that. So always get an opinion when you're making treatment decisions with a specialist.
A comment and then a question to what you were saying. This is my experience. I started my multiple myeloma journey at Northside because they diagnosed me. I went there for all the hematologic tests, etc. And basically, just when they said that I had multiple myeloma, they were willing to treat me. I was out of work as well, so they made that happen. That financially it was all covered, so I just went with Northside. But then I didn't get quite the results that I expected after doing the stem cell, and then I started to do more research at that point. And I talked to HealthTree, and I also talked to LLS, who are now Blood Cancer United, I think. And they told me unequivocally that the only multiple myeloma specialist in Georgia, Emory, not Northside, not City of Hope, not Piedmont, not any of those people. That's not to say that they can't treat you, but as Dr. Hoffmeister, I think, I'm not sure what your name, said, you may be DIYing if you're not dealing with a specialist, and that was definitely my case. So if anybody comes and asks me, I'll say my experience is that Emory is definitely a better place for me because they are the specialist for multiple myeloma in this state. That's what I would say. The other thing I had questions. So I wanted to find out about the precursor stages because I've heard different information. My understanding is that before you get to active multiple myeloma, you have one of the precursor stages necessarily. But I've also heard that it's not true. You can just develop multiple myeloma. So that was one of my questions. First, do you always have the precursor stage? And then secondly, do you go from MGUS to smoldering, or is it one or the other? And then how long do you stay typically in each phase, if there's any way that you can tell that? And if you see a doctor, if you had a doctor, I was diagnosed in 2023, and I saw my doctor a lot and did a lot of blood tests. Should they have seen signs that maybe we should have done further tests? And I'm not trying to sue them or anything, but I just want to get an understanding of, should this have been spotted by a PCP that you see often who does all these blood tests? Sorry, complicated, maybe. multi-part question.
So it is a complicated question in a way, and myeloma is a complicated disease. But typically, we anticipate if I were to somehow magically look at every myeloma patient, we do expect that they were in a precursor stage at some point, MGUS, and then smoldering, and then going on to myeloma. How long were they in each of these stages? It's depends a little bit on the biology of each myeloma, but it's possible that they were in MGUS stages for decades before they end up having a diagnosis of myeloma. And it's not always possible to detect someone in an MGUS state. Most of the times, when does somebody get a diagnosis of MGUS is that someone like a primary care doctor was trying to look for a cause for something. Say, for example, a kidney dysfunction, like, hey, why is this patient's kidney impaired? And they do a few tests to see, like, hey, could this be from myeloma? And we see a small amount of monoclonal protein. Or they do a few tests and they see that the total protein is high in the patient. And then they find out that that is an abnormal amount of protein in the blood. So maybe this could be a sign of myeloma, and that's how the path goes. So it's hard to say how long one patient has been, but we do think that every myeloma patient was preceded by MGUS and then a smoldering stage overall.
I was just going to say, to the second part of your question where you said, I was getting checked a lot, should someone have caught it? I think the reality is you could check someone's labs every month, every 3 weeks. Sometimes we don't catch that progression. Sometimes it happens quickly. In general, what we look for is those crab symptoms starting to develop. So anemia starting to develop. So maybe you always hang out at 13 and now you're at 11. And that's not bad, but it's not your normal. Or maybe your kidney's starting to get a little bit worse. It's not bad, but it's higher. So those are usually the things we look for. But we do say, even if you monitor extremely closely, even if you're with one of us, it can happen quickly. And sometimes we miss it. And the point I'm trying to get to is that is one of the reasons we have started moving towards treating smoldering. The point of treating high-risk smoldering is to prevent CRAP, to prevent myeloma end organ damage, to prevent someone from breaking their leg, breaking their back, getting on dialysis. So of other reasons, that is the reason that for high-risk smoldering, we think it's beneficial to treat that. Whether you do that off trial, I think we mostly prefer you do that on trial because there's still a lot to learn, but that's the rationale behind that.
If I understood you right, you were seeing your regular doctor and that they did not catch myeloma until the time a real event happened, a CRAB criteria happened. Anyway, so the big question that goes on in general is, why can't we screen everyone to see if there's a protein? So can I not get benefited? Can I not get diagnosed earlier? So whenever we're talking about any screening procedures, they should have an impact on the overall survival. So by catching it early, people are living longer. So that's why people do mammograms. That's why people do colonoscopies. But that has not been as well established in myeloma. By diagnosing early, are we preventing any symptom? Are we allowing the patients to have a better survival? There's a study that's ongoing in Iceland, or it has accrued, where they screened, it's a small country, so where they screened everyone and basically found how many people have this precursor lesion, and they're following over a period of time. So those results will help us in a lot of interventions that one can do, whether this could be applicable for a broader population.
So we wouldn't be able to catch this under your physical?
Not necessarily, because unless you're able to see an elevated total protein, so which means the abnormal protein fraction is increasing, so the total protein is increasing. So there should be a signal that one has to see. If you have a good primary care physician, sometimes they start this workup when they see an increased total protein.
This is a little out of order, but for the gentleman that was asking about which institution to go to, I was going to do a quick commercial. I'm a caregiver. My wife was misdiagnosed twice, once at Piedmont and once at Northside, and treated with chemo for the wrong cancer at Northside until we got down to Dr. Nuka, and immediately using the same lab results that had been used at the other institutions, was able to tell us exactly what was going on, what the treatment was going to be, what our options were. We left with enough reading material that day to choke a horse. But it is, Emory's Winship program is a world apart compared to any other. And I've been operated on in multiple hospitals myself. It is a whole different standard. So that's just that's not empirical, but that's what I would tell you.
Good afternoon. I enjoy your speech. My question is simply this: how much of a role does one's insurance plays in determining what type of service he would render? You.
So I came to Georgia 2018. In Georgia, there is Kaiser. And my brother, as I've told you all, lives in San Francisco, and there's also Kaiser there. And if I were to think about the only thing about insurance that you potentially have any control over, whether to have insurance, to be uninsured, if you have insurance, which one can you choose, and your age and Medicare and Medicare Advantage, or Disadvantage, Medicare Gold or not so gold. But never mind. If the things that you might have the ability to change given all of our circumstances and not endless resources. Kaiser in Georgia is a different animal than Kaiser in San Francisco. They have whole hospitals that are Kaiser hospitals in California, and Kaiser is much more comfortable in California than is in Georgia. So the only comment I would say on insurance is that the Kaiser, using Kaiser insurance to care for patients with multiple myeloma is significantly more challenging here in Georgia than it is in states where Kaiser is more common. That's my only insurance comment.
My statement concerns Northside versus Emory. Northside has doctors that can give you chemo, but Emory has these researchers sitting up there. That's where the information is coming from to them. So make that decision when you do. Do you want just the chemo, or do you want the thoughts behind the chemo?
Hello. Hey, doctors, over here. Thanks for being here today. So I do have two questions, one for SMM and the other for MM. And so for an SMM patient that is currently taking treatment, at what markers could we start again before, in case we see a rise in numbers, but not essentially meeting MM levels? Because essentially, I'm hoping that we can forever delay the progression to MM.
So I think if I understood you correctly, you're saying if someone has smoldering myeloma, they're treated, and then they start progressing again, and it looks like they're developing myeloma, what can we do something there?
Exactly.
Is that the question?
Yeah.
So it's a very good question. It's something that we talk about a lot. The data that we do not have any data like that. The only data that we have in treating smoldering myeloma is that they're treated, whether they're treated until progression on some of the early trials or they're treated, the standard currently is fixed duration. So most of the clinical trials that are ongoing or have recently been published have been treating smoldering myeloma for a set period of time, which is around 2 years. We don't have data for folks who were treated, had a response, but then progressed at X period down the road of retreating them. We just don't have that data. Well, I think that's a very interesting concept and something that we should explore. We just don't have that data. And so the current standard is you treat and you watch. And once that patient starts to meet or markers, criteria for symptomatic myeloma, you treat them for symptomatic myeloma.
Thanks, Doc. Now, for a patient that is newly diagnosed with multiple myeloma, I mean, it's great to hear that there's so many lines of treatments now, but assuming the patient does achieve a positive response, what would be the average duration they're in remission, or at least partial remission, until the next line of treatment?
So I'm sorry, I'll stop after this. So the remission time for Perseus. So the current standard of care is DARA-RVD, transplant, maintenance until progression. It's the current standard of care. If you were transplanted 10 years ago, you might have had RVD. So DARA-RVD, transplant, maintenance. The Perseus trial only has 6 years of follow-up or something, so we don't have the average remission. When they use computer modeling to project ahead, it looks like the average remission, which I think might be a little overestimating, is going to be 17 years. So we don't know, we have to give it time, but it looks like the remissions are over a decade. We can at least say that.
So 17 years, and that's 2 lines of treatment.
1 line of treatment. DARA-RVD, transplant, maintenance is 1 line. So that's saying we could get potentially a decade of remission. Now, that's average, so half is over, half is under, but that's very impressive, encouraging. And that is not survival, that is remission.
Thank you.
I think there was a question previously about using a 3-drug induction regimen. What would one expect? So that was data that Dr. Joseph presented. If you're a math person, I'll help you guide through. Every year, there's a certain amount of patients that drop off, in the sense that progress. That rate of progression is, think about it as 8% per year. So if you give a 3-drug treatment, get a transplant, go on to maintenance, that rate of progression is 8% per year. So in 4 years, 32% of the people will progress, right? Using the 4-drug regimen up front, that number is cut down by half. The rate of progression is 4% per year. So instead of 32% of the people progressing at the 4-year mark, there are 16% of the people progressing at the 4-year mark. 84% of the people still remain in remission. So that's what leads to the modeling that Dr. Joseph was saying. These patients can stay in remission beyond the 10-year mark, beyond the 12-year mark. But when we talk about the median, that is 50% of the people achieving that goal, and the other 50% of the people progressing before that time.
Dr. Joseph, you touched a little bit on plasmacytoma as one of the precursors. That's where my journey began, with plasmacytoma. And mine was in the bone, but you said it's outside of the bone. So can you talk a little bit more about plasmacytoma and why that makes multiple myeloma treatment more difficult?
Yeah, I'm sorry, let me clarify. So the word plasmacytoma really just means a ball of myeloma, so a tumor of myeloma. It can occur in different places. You can have, usually when you have lytic lesions in the bone, or they're in the bone, it's from myeloma inside of the bone causing a problem. They can start, those myeloma cells can grow outwards from the bone and cause a tumor of the bone. So that is a plasmacytoma. I can't remember your history, but I think you're referring to, you had a solitary plasmacytoma initially. That is one, you have 1 ball of myeloma, which we radiate and watch. What I was talking about is something called extramedullary plasmacytomas, extra meaning outside, medullary meaning bone marrow. So outside of the bone marrow, balls of myeloma. So you can have, for example, people presenting with myeloma in their liver, myeloma in their lungs. That is not a typical presentation for myeloma. We see it, it's not typical, and what that signals to us is this is a smarter type of myeloma, because plasma cells are supposed to home to the bone marrow. And when they have figured out how to ignore that signal, that is telling us that this is a smarter version. So that is different than what I meant. So I was talking about folks who are presenting with extramedullary plasmacytomas who are historically a little trickier to treat.
We have one up here.
Thank you very much. First of all, thank you all very much for all of this excellent information. I think you've really helped us all to better understand our diagnoses or possible diagnoses. I have a question. Is there any treatment for high-risk smoldering myeloma that is outside of clinical trials if you don't qualify for a clinical trial?
So there are a few options that we think about for high-risk smoldering myeloma. So one is Revlimid alone or lenalidomide alone. There was a study led by Dr. Loniel here, where we've looked at that. So that's something we can consider for high-risk myeloma. Another one is trying to look at combination of Revlimid and dexamethasone. The third option is daratumumab, which is a CD38 monoclonal antibody that was also studied recently on a clinical trial. And in general, FDA seemed favorable with the data. So we are able to get insurance approval should a patient want to consider treatment for their smoldering myeloma. These are the potential options of clinical trial for high-risk smoldering myeloma.
And follow-up question, the daratumumab, I know that the advisory board for the FDA approved it like 6-2, but it has not been formally approved by FDA. Does that mean that insurance will cover it?
Typically, when we have a favorable decision from ODAC, it's easier to get an insurance approval.
Okay, thank you very much, appreciate it.
I would like to add there. So for high-risk smoldering myeloma, like several studies, there is studies that Dr. Shah talked about looking at like Revlimid with dexamethasone, daratumumab, and then there's more aggressive studies looking at that too, like with treatment with daratumumab, carfilzomib, dexamethasone, or bispecifics even, or CAR T-cell therapy. So I think the data-based study was positive. It meant that it showed like an overall survival benefit in that study, but meaning patients that got that treatment lived longer. But I think what we as a group decipher from that is that identifying this patient population that has high-risk smoldering, they do need some sort of treatment. Now, what is that treatment? We actually don't know that, I would say, to be honest. So that's why I would really encourage, instead of getting something standard of care, like approved by insurance, I would actually encourage anyone that has the disease to actually sign up for a clinical trial, because yes, we should treat high-risk smoldering myeloma, but what is the optimal regimen? We don't know. So I would really encourage that you all would sign up for the trials, and that's the way we will have data to base these decisions off of in the future.
Hi. Thank you all so much for devoting your Saturday to us. It was very educational, and we appreciate it. My question has to do with the possible hereditary aspect of myeloma, and if someone could speak to maybe the latest research on that and connect it to the PROMISE study, if you are familiar with that, please.
So in terms of hereditary, so what we know is that if you have a family member with myeloma, say a father has myeloma, mother has myeloma, then it's possible that the children have slightly higher risk of developing myeloma. It's not, we don't attribute it to say a particular genetic mutation or something like that. It's just an observation that we have noted over time that, hey, of all people who have had myeloma, it's possible, it appears that there is a slight tendency for patients in the same family to have myeloma. But there is no a hereditary factor that we can pinpoint to that, hey, this is why exactly this is happening, or we can say anything for certain that, hey, just because there's somebody in the family who has it, that they could develop. PROMISE study, yes, they are trying to look at individuals where there's a family member who has myeloma, or as we all know that African Americans tend to have a higher incidence of myeloma, so they are looking at specifically African Americans who they're trying to evaluate for MGUS in this particular group of patients. So that is something evolving over time, but we don't have a particular answer that, hey, this is exactly why somebody could develop myeloma, or there's nothing hereditary that we have pinpointed to so far.
Yeah, as of now, I think we would look at such clusters of myeloma occurring in different families more as a shared exposure to a certain toxin as compared to a hereditary cancer. As of now, but like lots of research is being done, like with the PROMISE study, and maybe a few years later, we might be able to identify that one particular gene mutation that runs in families or is hereditary. But as of now, if it's being clustered in particular families, I would think of it as common dietary habits or common exposures to certain types of environmental toxins that they all had exposure to. So I would think about it like that.
So, thank you guys so much for all this. Thank you so much for being here on the weekend, hanging out with us, explaining everything to us. So in terms of, like, my grandmother was diagnosed with multiple myeloma when she was in her 70s. She lived until she was 93, no treatment. So, when I got diagnosed, I immediately thought of her, and I remembered asking and was told that it has nothing to do with genetics at all. So now, does it or doesn't it? And then I just heard Dr. Kish, I think, said it may have been due to exposure, that family members could have been exposed to the same things. And so I grew up in the city, and then my grandmother was in the country, eating everything healthy, not exposed to anything. And so it just makes it, the issue I'm having now is how do I, what did I do wrong? How could I not do it again? Or is there nothing I can do because it's genetic related? Do you know what I'm?
So I just want to clarify that you did not do anything wrong. No one did anything wrong in this room with any type of cancer. Some of these things are sporadic, right? Some of these things, they just happen. A friend of mine just got diagnosed with breast cancer. We have lived in the same place our entire lives. We drank all the same things in college. We did all the same things for 40 years. I don't have breast cancer, she has breast cancer. There are things we just don't understand that have completely nothing to do with anything you did or didn't do. First, let's just make that crystal clear. Secondly, I think just to clarify on the things that were said, we just don't know. So like with breast cancer, there are genes like BRCA1 and BRCA2 that we know predispose someone to breast cancer. That is just not something yet that we have found in myeloma. We have reported clusters in families. That happens. Myeloma is more common in the Black community. It is more common in first-degree relatives. We don't know why. Could it be about that they were in the same parts of the country? Could it be about exposures? Maybe. Maybe it was sporadic. Maybe it was bad luck. We don't know. So that's why studies like PROMISE and other are so important, because we're trying to figure that out. And ultimately trying to figure out, is there a role of screening, or how do we help the broader community and those who are at higher risk?
Good afternoon. My question is there a study or data that shows the incidence of secondary cancers for patients that have been on therapy for a very long time?
Okay. Looks like this is a broad topic, Ms. Mobley, so each of us will tackle one agent. So I'll start with the transplant, and I'll pass on the IMiDs to. So transplant, so melphalan is one of the carcinogenic agents. Like it is nothing but the nitrogen mustard that we used a long time ago. So it's an alkylating agent. This class of agents, when patients are exposed to, there's a likelihood, it's not just for the myeloma. We see that the same class of agents, when breast cancer patients are exposed, when colon cancer patients are exposed, the chemotherapeutic agents, so they have a tendency, or it's a risk factor for having a secondary malignancy down the line, and that risk is not too high. It's in the range of 1% to 2%. And these are called the secondary malignancies. These are treatment-related secondary primary malignancies. So that is from a chemotherapy standpoint. So I'll pass on the baton to Dr. Parekh to talk about lenalidomide.
So yes, so lenalidomide or Revlimid, given for many, many years, there has been some evidence to suggest that there's also an increased risk of second primary malignancies. Most commonly, we see myeloid neoplasms, so MDS or myelodysplastic syndrome or AML, or acute myeloid leukemia, which is a different type of cancer. But the risk or incidence of these cancers is very low, less than 5% is what we think. And whenever we do prescribe you Revlimid until disease progression, we are keeping that in mind, and we always do like a risk versus benefit analysis, and we think that the benefit of you being on the drug to control your myeloma is going to be higher than the chances of you developing some sort of second primary malignancies, and that's what we discussed with you.
Can you
Okay.
talk about the lymphoid neoplasms?
Yeah. So potentially any cancer treatment has a chance of developing secondary cancers in the future. But we specifically also have been studying, and FDA specifically has been keeping a close eye on CAR-Ts and secondary cancers from after somebody getting CAR-T therapy. So there are two groups of malignancies that we've specifically seen after CAR-T. Again, it's in very few percentage, like 5%, 5 to 10% range overall. One of them is myeloid neoplasm, just like after transplant or after Revlimid, we see MDS that can happen after CAR-T therapy. The other particular type of cancer that we have seen after CAR-T is lymphomas. Like we've seen that there have been a few cases where the CAR-T therapy leads to a neoplasm, like a T-cell neoplasm, so like lymphoma that's being derived from the CAR-T therapy itself, that can happen. It's seen in very few patients, but that is something that FDA is also keeping a very close eye on, probably in the range of 1 to 2%, like overall.
Okay, one more question, our last question.
So it's more of a comment and a question. Back to commercial time with the comment for the gentleman. I think you figured this is a room of bias towards Emory, and I want to give you my anecdotal experience. I was at Piedmont when I was pre-diagnosed. They wanted to put me on radiation to manage the pain that I was having in my chest. And fortunately for our contacts over at Emory, we were able to speak with Dr. Lonio, and he said, no radiation, because radiation would negatively impact my bone marrow. That could potentially impact me getting a stem cell transplant further down the line in the treatment. So by working with, if I stayed with Piedmont, I may have negatively impacted my treatment progress. I'm glad I came over to Emory because I went through the immunotherapy, stem cell, I'm on Revlimid, and I'm MRD negative. And this is a year and 9 months. So don't go to your wife, don't look any further, just go to Emory. I'll take my $100 for that. Secondly, my question, I have obviously multiple myeloma. My uncle has multiple myeloma. He's older than I, obviously. He's not doing well. It's just because of his age, and he has other comorbidities, so that's not helpful. His brother, my uncle, died. He had amyloidosis, and we estimate that 2 other of my uncles who died previously to them died very similar ways around the heart. So we estimate that they had amyloidosis as well. Is there research looking at the linkage of myeloma and amyloidosis? Do myeloma patients develop amyloidosis? It's a lot of questions out there.
The only thing I'll say is, or I'll say a few things, but the first thing I'll say is there are multiple types of amyloidosis. There is a type that's associated with myeloma, but there are many types that are not. And the most common is something called TTR amyloidosis, which is a hereditary type of amyloidosis. It's more common in the Black community, and it's more commonly presenting in older folks. So if someone is presenting later in life with heart failure type symptoms, it might be, I'm just guessing, it might not be myeloma-associated amyloidosis. That's the first thing I'll just say. That is clearly hereditary. So if that's in multiple family members presenting at a later age, that's different. That could be a different thing. That's the first thing I'll say. Amyloidosis related to myeloma is absolutely related to myeloma. So there is a subtype of amyloidosis called AL that can occur with or without myeloma, but is because of abnormal plasma cells making abnormal light chain. So when you have AL amyloidosis, you have the same type of myeloma cell making light chain, but for reasons we don't understand, instead of turning into myeloma, that light chain will fold into a weird protein and deposit into organs, like the heart or the kidneys. And that's how amyloidosis, AL amyloidosis presents.
Okay.
I had a separate genetic test done, and I have sort of the precursors to TTR, which makes sense to why my uncles had it.
So we have folks who have both a plasma cell disorder and TTR amyloid. That's not unheard of. Not particularly common, but we absolutely have that.